Okay.
Okay. I think we're recording.
Wonderful. Okay, I wanted to thank everybody for coming today, and I am here to do my first fireside chat on a 100-degree day, and so I hope we don't need any fire at all. And I wanted to introduce myself. There are people here that know me really well that work with me every day, and there are people that are hopefully going to be working with me more in the future. So just to give you a little bit about me, I have a PhD in social and health psychology, and my expertise is behavioral change, how to help patients take positive health behaviors. And I was recruited to Houston Methodist 2 years ago in multiple academic and leadership roles. And I want to thank Drs. Gaber and Gobriel for trusting me, for partnering with me on all of these amazing ways. I also want to thank the Research Institute, who backs me 100% in what I'm doing. So I'm both the Director of Patient Engagement, Diversity, and Education for the Transplant Center. I'm the Deborah C. and Clifton B. Phillips Centennial Chair for Clinical Research in Transplant Medicine, and I'm a professor in Outcomes Research in Surgery here and a professor of Population Health Sciences and Surgery at Weill Cornell Medicine. So I was recruited here as a full professor, and I wanted to really kind of celebrate the accomplishments that I've done to this point and talk to you today about where I'm going in the future. And I want to really also celebrate that I've really had the opportunity for 20 years to work in 3 of the leading hospitals. I started my career at Washington University Medical Center in the School of Medicine. I got tenure there. I then left Washington University and I became an associate professor and then a full professor at UCLA. And I had an amazing second appointment as the deputy director at Terasaki Research Institute. So for people who know transplant, Paul Terasaki was an innovator, and he built a research institute to look for out-of-the-box paradigm shifting initiatives in transplant. And then finally, I came here 2 years ago in the middle of COVID, didn't know what I was doing, trusted some amazing people that are probably on this call. And as I share today, one of the biggest things that's very important to say right from the beginning is my deep commitment to team science. And what I mean by that, Sheryl Sandberg actually talks about this in her Lean In book. But the point is, when you meet someone like me and we talk briefly, it can sound like I had a ladder of promotion, and it makes sense, right? I got a PhD, an assistant professor, an associate professor, and I moved up a ladder. Well, actually, the right metaphor could be something like a jungle gym. Because the key thing with health services research, which is what I have been studying for 20 years, is that this isn't something that one person can do by themselves at all. You actually are working within the hospital systems with all of the amazing people there, with research partners, with people inside and outside of institutions, with patients. And you build an organism, a jungle gym organism with a lot of different points of power and with an ability to pivot, because I think my team would be nodding here that it's not easy to do health services research and you can't just have one way to do it. The other part that I didn't even realize this, but we had to submit a summary of the number of people that I've written papers with in my career, and it's over 240 individual collaborators. So I'm speaking now on behalf of the Jungle Gym of my partners, and I want to show you what we've done. My current partners on my current Houston Methodist Jungle Gym look like this, and I want to celebrate. Many of them are on the call right now. And I want to say that what we've done in 2 years could not have been done without them. And what we stand for as a team in the space of patient engagement research is that all patients have the right to make an informed choice about their treatment. Each patient is unique and has to decide what's best for them, and that we can work together to lower inequalities and access to the best treatments for our patients. So because this is a fireside chat, I thought I'd take a second and I'd kind of say, how did I get here? Like, what were my decisions? Why did I become a person studying patient engagement research versus many of the other areas that I could have studied or careers that I could have had? So I want to introduce you to my parents. This is John and Karen Doggett. So my mom lived in Milwaukee, Wisconsin, and she was getting her degree in social work, and she was assigned to an African-American church to help be a teacher and a social worker for that community. And my dad, who lived in Ohio, took a year of volunteer service where he wanted to help reduce disparities. It's now a program called AmeriCorps. And so he took this year of service and he was assigned to the same African-American church. And my parents met and fell in love. He drove the bus. And my mom, he'd drive by with the bus and wave to my mom, who was in the classroom. And the thing that I'm so proud to be their child, because they were marching for the civil rights movement in the 60s. They got married in this church at a time where no white couples get married in an African-American church. And they have to this day been major advocates for social justice. And my mom, part of the reason why is because my mom was an immigrant. This is my mom. My mother is the oldest. She's in the upper left, and she's the oldest of 9. And what everyone asked me after that is, do you guys have a big Catholic family? And I said, yes, we have a big Catholic family. So my mom is one of 9, and her mom came over from Croatia and with her family of 11. So I'm actually the third tier from an immigrant family. And if we look at what I've been able to make accomplish, it's pretty humbling and amazing. And my mother was the first person to go to college in her family. The stories she shares are things like finding change in the bottom of her purse to make it through for the month and sewing clothes for her family members. Now, what's amazing though, when you're part of a big immigrant family, is there's a ton of love and there's a ton of kids. So those 9 people made all these people. And this was, my grandmother is sitting in the middle of this image, and she's in pale pink and almost the dead center. But we came to celebrate her birthday or something like that. And all of our family members that are linked to a certain child are in the right color. So my mother is in turquoise, my brother is in turquoise playing the guitar. So we were part of a big Catholic loving family who teamed up when things got hard. So for example, there would be an email where somebody would say, we need we need some money because one of the uninsured people in this community needs to get a blood transfusion, and everybody would give $100. And then that's how we would afford that. So I want to say that being part of this family is never far from my mind. I am present to the fact that this is the situation for many of the patients that we take care of every day. And I have a lot of both respect for this family and in terms of their ability to deal with things, and also to kind of see how we can make it better. So this is who I became when you become a person growing up in that family. And this is my 5th grade picture. And I was so proud of being a Girl Scout that I wore it to my picture, which is hilarious. And I think the thing that when you're part of this family, it's a faith-based family, it's a big family. It's like, how do we help each other? How do we love each other? That's fundamentally where I come from in everything that I do. So I've got a Girl Scout in me, and I go on for my PhD. And I am at Washington University at the time in the Department of Psychology. And I didn't have a lot of money, and Washington University paid for my school, but they only gave me $10,000 a year to cover my rent, which is great, actually. It could, in St. Louis at the time, I could cover 10 months with $10,000. So 2 months, I didn't have any money. So I needed to go to work. So I asked anyone if there was a study that I could be a part of to cover my rent. And a psychologist said, I have one. We need to call living donors. And we need to ask them if they were harmed by donating their kidneys years later. So the big fear at the time in the 90s was that somebody was generous enough to donate a kidney to someone, and then 10 years later, the marriage broke up, they don't like the person anymore, they lost their job or they lost their insurance because they donated a kidney, they regretted it. So the whole idea was, I joked, this was the worst case scenario study. So imagine a young professional calling people and basically saying, did any of these terrible things happen to you? And just calling one after the other after the other. And I had a life transformational moment when I was part of this study, because not only did they say those things didn't happen, they actually said that this was one of the most profound experiences as a human being that they had ever had. For women, they talked about how this was equivalent to giving birth. And for one woman that I always share about, she said, I became a poet because I got what life was about. And I was like young and impressionable, really wanting to make a difference. And I was like, these people are the best human beings I have ever met, one after the other. It was the most profound summer. And I said, well, is there anything we could do better as a healthcare system? And then they shared, although we didn't regret it, they said, we really would like it if people could give us some more information about living donation, because we were so scared that we would not be able to donate, that we didn't ask enough questions. So they were so committed to helping that they weren't asking questions about various important things like, how long am I going to be in the hospital? And are there any risks to me? And is it safe? And, all these things that you want these wonderful people to be able to ask. So I'm sitting here listening, all inspired. And I thought, I could design education. So this was education that I developed. The first piece of education I developed in my career. It was a one color book because it was expensive to have 5 colors, but it answered the basic questions that they brought up about what things I need to know, what would help me. And I was really proud to contribute to these wonderful people. The thing that they shared and that I never forget, and why I love living donation so much, is they talk about if someone can donate 1 kidney, which is what's in the bowl, sorry if that's too gross for somebody, but that all of this life is possible. Okay, these are real people around this square here. These are donors, these are recipients, these are people that their life is actually improved by healthcare. And I know we do lots of good things in healthcare but we often can't actually restore people to life where they have freedom and joy and they get to do what's important to them. And when I found this way early in my career, I was committed to these people. I was committed to helping their experience. The other thing is I'm very pragmatic. So we've got 335 million people in the US right now. If less than 1% of those people donated 1 kidney, we could literally eliminate the organ donor shortage entirely. And I could be part of helping to solve this. So unlike a lot of things that I didn't feel I could chip away at, I thought this is really worth going for. I could actually, in my lifetime, make a difference. And I'm not saying I'm the only one. I'm saying collaboratively, our field could make a difference in this by doing some kind of paradigm shifting innovation. So going back to the patient engagement research lab, what are we doing to try to really explore transplant and patient engagement? So we are working at many levels all the time. We're working within the community, within the hospital, we're doing research trials, and we're working nationally to improve things. And if you look down the middle, we're really looking at, does everyone have equal access to transplant and other treatments? How is the communication and education built so that we can connect with people, inspire them? Are the doctors and the patients connecting? How do we improve what's happening here in the hospital? Now there's amazing technological advances. Are we utilizing them optimally to improve patient care? Are we building pathways that are connecting with patients? Are we hearing patients? And finally, are all of those things resulting in better patient-reported and health outcomes? So fundamentally, I'm a patient advocate. I always say that. I have a lot of credentials, but that's what I am. And I think our lab as a whole is a lab that is a patient advocate lab. So I want to introduce you to a couple things that we're doing and kind of show you historically what I've been doing and then also what my current team is up to here so that you really get it. So the first part that is there for me is that there are patients in need of greater support. That's always been true. And often we only know that when we lose them, right? So we start our process of care and then the patients aren't here at all, 1, or 2, that they in the middle of our care process, we lose them. So this has been a really exciting development that I've been part of. And I want to introduce this to you guys who aren't in transplant. And this is a national image talking about a patient. If you look at the middle blue line of patients moving through the transplant pathway. So the people are considering transplant and seeking a center and going forward for referral and evaluation. And hopefully, as you move to the right side of the screen, getting a transplant and doing really well and living for a long, long time. That's what we all want. There are so many people here clinically working on this. There are researchers working on this as well. So if you also look at the yellow line, so since people can donate organs, you can donate organs while you're alive. That's the living donor pool. So often friends or family members donate, and they are also connecting into the pipeline. You also have generous people who pass away. They're in the donor family area of the bottom of the screen. where they decide to donate organs, and then organizations like called OPOs, the Organ Procurement Organization, the one we have here is Life Gift, are really making sure that the gift of the person who passed away is connected to the person in need. So this is the complexity of what I call a care delivery pathway for successful transplant. Now, who is not moving along successfully is what you might ask yourself if you look at that pathway. And so sadly, we know that for living donor kidney transplant, which is the best type of transplant, since 1995, we've actually had a reduction in the number of Hispanics, Black, and Asian patients who are able to receive a living donor kidney transplant. It's getting worse. And so this is really concerning. And there's a call to action that we need to be doing this differently. And so that is one group that are challenged with this, but it's not just about race and ethnicity. So low-income racial and ethnic minorities are less likely to come into our center and be waitlisted. They're less likely to make it through the steps as they move forward. And then they even may not adhere to the medications, and they may not show up for certain things. So you just look at where we're losing patients. There's definitely a space for studying disparities in transplant that has to happen. It's also about social determinants of health. We have so many issues that are not about health that are affecting our patients. And up to this point, I was hearing Ryan Jackson's presentation yesterday, and I'm so inspired by what she's doing. Now within our institution, we have to check to see if people have access to food, that they have running water. These kind of things, understandably, you're going to drop out from a medical appointment if you don't have what you need on the ground. So we need to be more inclusive of those things and knowing those things and intervening with those things when we find them. So just to give you a picture of our patients here, I've been working with David Shu and Steve Jones and many, many other amazing people. I can't thank them all enough. And we're really looking at what's happening in our institution. So there's about 4,000 individuals who presented for evaluation of varying races and ethnicities. And what you can see if you look at this table is that we lose people, that only half are actually waitlisted within 12 months of evaluation, and 13% are transplanted a year later. But if you look at the non-Hispanic Blacks and Hispanics, these communities are only getting transplants. 7% of non-Hispanic Blacks that present here ultimately get a transplant, and only 12% of Hispanics. So I'm really listening. And one of the things I'd say that I do very well is I'm listening for what is missing in the system. Where are we losing them? What are we not doing? And I know that Dr. Gobriel and Dr. Gaber have asked me to bring whatever strengths I have to contribute, because they're listening as well, and all of the leaders are. So we were able to get a grant since I've been here to really try to build risk indices. And I'll explain what that is. But if you look, patients who express interest in transplant, but they never show up at that evaluation point, who are those patients? How can we help them? What about patients who begin transplant evaluation, but they're never listed? So they don't make it through our whole process, and they're healthy enough that they should be able to, but they just don't make it. And then finally, patients may get through and be listed, but they never get transplants, which is what we all want. We want them to have the longer life possible than living on dialysis. So we've been using AI and machine learning to build risk models. And we're using both internal data within Houston Methodist. We're also using social determinants of health data that we have that are available to really try to explain the people who are making it through versus the people that are dropping out. And you can see trends that are consistent with other literature, that we're finding patients that really do need our support, and patients that we could actually realize the day that they enter our Houston Methodist system that we need to bring those supports to them right now. So we're excited about the fact of building a risk index, but we're even more excited about trying to help. So the big question that happens after you build a risk index is, what do these individuals actually need? So there's so many gaps. There could be something in their fear about what's happening, socioeconomic challenges, the need for better support, language challenges. There could be something that we didn't, what our risk indices are helping to overcome are improvements in our healthcare system's detection of patients in need for support. And we're now have the ability to interview patients that are fitting certain risk models to see what would help you more. So there's a process of both looking at people that are at high risk of dropping out. There's also a line of work we're doing where we're looking for patients who are really successful that we wouldn't assume would have been so based on the challenges that they're facing, to try to bring the lessons that they learned to patients that are in similar situations. So my team are working on that. Now, the other part that gets me, because I'm a social psychologist, and the difference between a clinical psychologist and a social psychologist is we're working at improving the system so that everyone's better supported versus individual one-on-one change. So what I geek out about is that how do we build an intervention where we can use excellence in patient care, which we already have here, plus better education, plus technological advances so that the patient is supported in many ways such that they can be more successful moving along the pathway. So I also talk about this as a metaphor. A multi-level intervention is basically saying you can't just give a patient a brochure and think that's enough. A brochure plus a conversation with a provider plus a reminder by text, plus you can see that that has a higher chance of working than just if you say, I tried just to talk to the patient. We also know that a patient's social support network, in the case of transplant, they're living donors, involving a whole family also increases the ability for things to be successful. These are hard to do. One of the reasons why I'm here is that this is a system very well set up that we can build and test multi-level interventions together. It's not that I can do that, but in partnership with Dr. Gaber and Gabriel, in partnership with Roberta Schwartz, different people, the community, also the patient engagement leadership here, all of these people in partnership could actually say, could we make a difference on the ground? And what literature says is if we can be bringing the strengths of many groups together and focus on what is modifiable, then we can actually make the difference that we're setting out to make. So I've come in with about, I've studied over 100 studies looking at the efficacy of many different things for communities that are more likely to drop out of the process of transplant. I've also been part of leading consensus conferences so that there are recommendations that we know that we want to bring here. And I've been working particularly with Black and low income patients in certain trials that we have, because it's just, there could be something unique where we need to individually tailor the support that we're providing for certain communities. It isn't that we can put a Band-Aid on everything. We may have to uniquely target messaging, uniquely target interventions. And I'm really honored that Dr. Davis, Dr. Lashara Davis is here with me. Her expertise is health communication and really guiding tailored messaging for communities. So I've built a lot of education. That's where I started my career. And you can tell I started my career here because there's a disc you put, that we don't have streaming anymore, right? There's a disc in the middle of this. So, but what's great about what I wanted to say is what's great about this program is that this program is honoring that people are at various levels of readiness. And so this isn't a program to say you have to get a transplant. This is a program called Explore Transplant, where people are exploring the options to get a transplant. And I did this program and did this as one of the grants that I accomplished. And what we showed was that if people got access to this program in a guided way, with a provider providing a guided set of conversations and the patients thinking through after watching videos of patients that are similar to them and reading information, many patients were more ready to pursue transplant, more knowledgeable about it, and were more likely to pursue transplant by contacting transplant centers to start evaluation. So this got a little crazy because after this study was shown to work, there are 250 transplant centers in the country, and they were like, wait, you can use education to get patients to come forward to pursue transplant. Can you teach our teams to do that? And I was like, oh no. And this is an interesting moment of the oh no, and then the breakthrough. So there are 6,000 dialysis centers who are providing care for patients that their kidneys don't work, and 250 transplant centers who are trying to help patients get kidney transplants. So how do we help all of the people receiving care in these green dots and these red stars? So, you know, that little Girl Scout, you know her. She said, okay, how do I have to do it? I've got to train dialysis providers. They're all in those 6,000 centers. I've got to get them the information that does work and teach them how to have effective conversations. I need them to go into their centers and find their eligible patients. I need the patients to go home and talk to their family and friends and potential living donors and have more people show up for transplant. And then everybody can live a longer life and then it will be great. I can do this. Okay. So I'm always hopeful. So the celebration I want to say is so many great people across the country partnered with me on this big dream. And we've actually trained 10,000 healthcare providers how to use this program. We've validated measures of readiness so that rather than providers giving everybody the same thing, they now are more sensitive that some patients are in early stages of readiness. They need to be treated very gently and respectfully versus people who are hungry for transplant and need to get different types of training. So I have flown all around. I was a Southwest like A-list person for a while, and I've gone to some wonderful places and met wonderful providers, both dialysis and transplant. And I thought I was done, to be really honest. Yay, I moved around the United States. It was fun. Okay, so then I get a call from Canada, and they said, we love what you're doing. We want to build Explore Transplant for the province of Ontario, but we have to redo all the videos and all the education because our Canadian healthcare system is totally different from the healthcare system in the United States. So would you be willing to do this? So I said, okay. So then I know Canada very well. I could educate about Canadian transplant now. And I had this incredible experience of getting to learn about the challenges of Canadian transplant. And what's interesting about Canada is that it's larger than here and there are fewer transplant centers. So people are very far away. And how do you deal with geographic challenges? So that was really great. And I got to go in and build a new program and meet these amazing people. And they took this on, and then they did a provincial Explore Transplant intervention where this was part of many multi-level intervention components. And I was honored to be there. And that was great. And I thought I was done. So then I got a call from Singapore, and these are wonderful people from Singapore. And the Ministry of Singapore said, we want to figure out what's going on with transplant education for our patients. And they had the opposite challenge of Canada because Singapore is an island and they've run out of space for dialysis centers. So they need to get people to transplant because they don't have any geographic area left for the number of people with kidney failure that need dialysis. So I was like, whoa, where is Singapore on a map? What is going on? And I learned about amazing people in Singapore. And they're still my friends to this day. And every time I see them at conferences and they send me pictures of their kids, it's just beautiful. So all of a sudden the world got smaller. And I really got that we're all dealing with the same thing, many different challenges. And I learned where Singapore was on the map. So I think I'm done. Wow, Singapore is great. Canada's great. So then I get a call one morning and it says, undisclosed number. And I pick it up and they said, hi, we're having an organ donation summit. And we'd like you to speak about the need for equal access to information about transplant. Would you be willing to do that? And I was like, yes. And this was an experience that, you obviously are never going to forget, where I stood at the blue curtain where President Obama at the time was supporting this summit. And I said, everyone deserves equal access to the best treatments possible, and that we need to build a clearinghouse of resources that are publicly available. And what I'm really proud of, this is a great, keynote moment for me, but what's really great is we built it. So this is now in existence, a health literate program on the UNOS website that exists that did not exist before. Nobody in the United States, they were getting all this dialysis education that we were sharing, but there's now an online program that was created by the consortium of leaders of the Organ Donation Summit, and I led this so that people can come here and learn. And this was, again, like what's wonderful about careers is that you don't know what's next. You just have to step and take the next right step. I always say that. So where are we now with education? So my team is still going. It's amazing. So my current team here are running 2 clinical trials for over 1,000 patients here at Houston Methodist and in our community. The first trial is exploring a tool called Linked by Love, which is about edutainment. And I think this is fascinating because this is about, can you use stories like something like a Netflix series, and can you embed information and get people who don't care at all about chronic kidney disease and transplant to learn? And can this type of education help them be more curious about taking care of their own health and also pursuing transplant or being a donor at another point? So this is fascinating. This is cutting edge type of education. So proud to be working with a group out of California, the Mendez Foundation, who have built this with, with people who work in television and movies in Los Angeles. The other thing we're doing is we're really breaking into animations. Animations are wonderful for low health literacy patients and often make very hard to explain transplant concepts very clear. So we have partnered with Health Literacy Media, and we have really amazing animations that are going to be, HRSA is really interested in making these available nationally when we get done. So the other thing I wanted to say that was just exciting, that goes to, like, you never know how your career is going to go, is, so my team here in the last 2 years have built these animations. We built a script, we filmed them, we taped them. There are people in transplant here that Bethany and Joe that are actually voices of the animations. And so HRSA said, this is really great. Can we have it afterwards? And I was like, please, let's get animations to patients who need them. So I got a call from the World Health Organization, and I was invited to go to Spain, where we're setting global goals for what education should be about pair donation and making sure there's measures of informed decision making. Because currently, pair donation, there's no education, there's no measures. And so there are patients across the country that are not even getting the opportunity for pair donation, that don't have any education about it. So I joked, I go, I got to Singapore, but now we're going global. And that is just, to me, like, that's why that little Girl Scout got up in the morning and got to work. So the other part that had me come to Houston Methodist, and I am so excited about where this might go. We're not there yet, but let me show you what we did at UCLA. We studied how to build technological innovations inside of healthcare to increase health outcomes. So this was a trial called Your Path to Transplant. And we basically provided people with education similar to what I showed you. We also provided them with phone coaching and support for socioeconomic challenges. And we wanted to see, would this matter? Does this help those patients along that pathway, that subway map, moving forward to transplant? And it found that we did, that at 18 months, the people who got access to those resources were more likely to be listed for transplant. And wonder what we could do here based on all of the transformational technology that's available that can be tested. So I don't know if you remember the story, the beginning of the story, about how we talked about, can we find more living donors, right? So wait, 100,000 people, where are they? So some of them have come to the transplant center already. And so every year about 7,000 people become living donors. But the thing about it is those 7,000 people, every year there's another 7,000, and it's not going up. So we are getting 7,000 generous people per year, but wouldn't it be great if we could get 10,000 and then 15,000 and then 30,000, right? So how are we going to do this? So I love my boss, Dr. Gaber, and he's like, what are you doing now? He often asks me that. But the thing that we get is we've got to go out into the community, and we have to find those generous people, and we have to inspire them and get them to come into our transplant center as potential donors. So how do we do this? So when I was at UCLA, there was a patient who was part of one of my studies, and we offered the patients like $20 or something for doing the surveys. And she called me and she said, that's not a lot of money, and I want to donate to your cause because I'm a patient who needs a transplant. I want you to solve the organ donor shortage for me, please. And I was like, that sounds great. And I said, one idea I have is maybe we're missing something. Would you be willing to support me going to TED, where there's a lot of leaders who are experts at things other than transplant? And can I just workshop, how do you solve the organ donor shortage with people who aren't in transplant? And this lovely patient supported the cost to go to this very expensive conference so that I could basically ask smart people questions about what is missing. And what they told me at TED, so imagine there's people in entertainment, in healthcare, in business, right? Technology, all of these types of people that want to come here and be, kind of be a sponge and think about the big ideas of the time. And they said, your area is so beautiful, but you're using education. You should use the tools of entertainment. You should use the things that we're doing now, video, all that. Why are you doing this in such a boring, out of date way? Okay, they challenged me. So I said, okay, how do we do this? And I said, all right. So one of the things they said is these stories of people who have donated kidneys are life-changing when you hear that. I told you about my life-changing experience, but I wanted to invite you after this call, you can go to livingdonorstories.org and you can hear stories. And the people that are pictured on this living donation storytelling project are real people who've either received a living donor transplant or given a living donor organ, or family members or people in need. And this came from TED because they said, wow, if we can, what if we can get these stories to people, because this could change lives. And even if you watch one of these stories and you thought, could I ever do this? That's sometimes all you have to think. And then at some point there might be something in your life that means that you could step forward if this is the right thing for you. For some people it isn't, and I respect that fully. So we have this amazing library now, and I want to thank my team because we've been adding stories to it. We're going to be adding a Spanish language program to this, which is so exciting. I'm like ready to go on that one. And we really want to say, like, if you want to hear these real people, you can see they're at home. They're not perfect. They're normal people in their houses talking about what they wish they knew, why they did what they did, recommendations for other people. It's really a beautiful group of people again. And what I love about it is we're also learning that you can sort the stories for something of interest to you. So you could sort it for a question you yourself have, or you could sort it to find people who look like you, speak your language, whatever helps the community. So we are in the process of building libraries of diverse stories of people who've gone through this and letting their voices connect with people. I can be enthusiastic about this, but when you hear somebody who's been through this and who's on the other side and who has wisdom to impart, that can be even more powerful than I am. But I'm also a geeky researcher. So we did a paper looking at, could stories actually improve health? And there is so much work to be done here because there are so many communities that do not trust healthcare providers and who have basically validly not been given the respect that they deserve. So can we use storytelling to connect better, to get people curious, to get them moving forward? And there's fundable grants that we could get to explore this. So we're building that now. And one of the fascinating things that's appeared since we've been here is Dr. Davis and I, we are partnered with the University of Louisville, where we are looking at Reddit. And you go, why is she looking at Reddit? What is going on? This is a Dr. Gaber question. And basically there are people in Reddit typing about questions they have about being maybe a donor. And can you imagine if you could send stories or education to the people that are in Reddit asking questions, needing information and insight? That's a way to find more potential donors and get them hopefully moving forward to a transplant center. So I really want to say at this point in my career, I really have a deep, deep belief that our patients know things that we do not know. And so I care a lot. I have a lot of, information, intelligence about this area, but I think the responsible place to stand right now is that there are things in our healthcare system and in our clinicians and in me in our blind spot. And what do we not know? Without fully honoring all of our training, but what can our patients say to us that can improve care at a transformational way? And I started a partnership with a group that I just love, the Transplant Recipients International Organization. They're called TRIO. And they came to me, and this is an example, and they said, you know what? Our patients are all getting cancer 10 or 15 years out. And they realized that they didn't listen when we were telling them that there was a risk of cancer when they got their kidney years ago because they were so excited to get their organ. And now they have cancer and they're kind of like, whoa, I need more information. Could we build a tool so that we could improve transplant recipients' risk understanding about post-transplant cancer and what they should do and how they should monitor their health going forward as the organ's still working, which is great, but the chance of cancer is increasing. So I had the privilege of being a researcher and a partner, but letting the patients lead to build what they saw needed to be done, which was that there be post-transplant cancer information for recipients out in the public eye. And we published a paper on this. And this is the first paper that I published with patients, and I have more in the queue. But the experience that I had out of this, and then what they're doing next, which is really looking at how patients should be supporting patients through peer support programs. They are figuring it out on the ground better than we are within the healthcare system. And how do we integrate the wisdom of real patients, whether it's digital storytelling wisdom or peer support wisdom, into our care? Even if we do our care and then we refer out, how do we build a care delivery system to allow the patients to contribute to each other in a better fashion? The other part is there's something called patient activation. And if you look at these questions, this is a canned measure where it's like a patient is empowered to partner fully with their healthcare team. We know that when patients are more empowered, they ask questions, they come prepared, they're more adherent to medications. But the other part, what happens when someone isn't an activated patient? So I've been working with a lot of amazing patients, and basically they said, look, we need to talk. If you're not activated to start, you need to connect with a patient support person to help you learn how to be activated. So lots of initiatives are happening there, and it's really exciting. I wonder how we can get our patients to become more activated. So in closing, why did I come here? Like, I've obviously been doing a lot. I've worked in amazing places, right? I didn't need to come to Houston Methodist to begin my career. Why did I come here as a full professor? So the first part, and I want to honor Kelly Maresh, who's on the call right now, is she and I were talking as I was moving here. And she's like, I know why you're coming, because it's a blue ocean here. And I was like, Kelly, I do not know what you are talking about. And she explained that this was a business concept where when I was at UCLA, think of all of the transplant centers that are in UCLA, the competition, all of the research, the whole thing. Houston is an amazing blue ocean for innovation, for opportunity with patients. There is room here and opportunity here galore. And I have found that to be true in my first couple of years here. The other part is that this is such a place committed to optimal patient care. People say it everywhere that you go, but I really have experienced it in the hard work of people here, in the heart of people here, in the openness to have my big ideas be received and thought through and contributed to and improved upon. This is a place that understands and shares my passion for patients at a level I've never been, although I fully honor those other places. The other part is this is a place full of challenges. This is a city that is ahead of the curve in the challenges that need to be supported in healthcare. And by being here and by fighting the good fight alongside so many good people that are in the hospital, that are in research, that are outside in the communities, we can try to look at the economic challenges, in the racial and ethnic challenges that we're finding, in the social disparities of health that need to be figured out. I don't think I could ever live in a place that wasn't diverse at this point. This is where I need to be to do the good that I want to do. And the other part I wanted to say, and I just wanted to make sure that as the Research Institute continues to evolve, I think one of the big advantages to bringing health services researchers here and patient engagement researchers here is that the NIDDK is very loudly championing this kind of work. So this is their strategic plan. And what you see here is that they want to fund studies that advance research to disseminate and implement evidence-based prevention strategies and treatments in clinics and community settings to improve the health of all people, and to advance stakeholder engagement, including patients and other participants as true partners in the research. So everything I've been doing this for 20 years, and often no one cares. Education is not as sexy as transplant. But now what everyone is realizing is that we're leaving people behind, that we need to be listening better, And if we don't, we're going to lose. And they're putting actually financial grants linked to this, which is exciting for the Research Institute and the visibility of the grants that we can win together with the Transplant Center, with patient engagement, with other partners that I have yet to know, but I'm sure I will. So what's exciting, if you look down the funding agency line, is whether it's the National Institute on Minority Health and Health Disparities, the Agency for Healthcare Research and Quality, the NIDDK, or the Patient-Centered Outcomes Research. There are just so many directions with the kind of work we do. It just keeps going. There are pages and pages of these, and it's exciting and overwhelming, but like for the Girl Scout in me, I'm fine to keep going. So for my next steps, and our next steps, the steps of the patient engagement research lab, I am so excited by the quality and the size of the diverse patient data that we have here on transplant. We have some of the best data in the United States on learning how to provide transplant care. Linda Moore and David Hsu have built a registry for every organ type that is going to allow a lot of researchers like me to be able to ask questions and get the questions answered on transplant. We're also trying to partner now with large other centers, transplant centers and healthcare systems, so that we can begin to look at important factors both in Houston and outside of Houston in a safe data sharing way, which has been fun to build with Steve Jones. The other part to me that I've had just the most creative conversations with some of the best hospital people I've ever met, honestly, is how do we use transplant as a test bed? So there are patient experience innovations that are happening across the hospital. There are social disparities, data partnerships that are happening across the hospital. We have CareSense, we have texting systems, all these tools that have been invested in by Houston Methodist. How can we look at transplant and potentially other areas, if there's other people listening, where we can say, let's build this right, and let's show that we can increase health outcomes, not just that patients' experience has improved, which is obviously very important to me, but then also they are doing better. They have less pain. They are not depressed. They are having a longer transplant. Like, that's a win for every metric that we all care about. So we're working on our first study on this that we're going to be submitting this year on post-transplant people returning back to their normal life. And I'm excited to build that with a lot of partners that might be listening. The other part is there is a new and exciting, this has been just great, community engaged partnerships are just popping up everywhere. This is no longer Houston Methodist by itself. This is Houston Methodist in partnership with TSU, with Rice University, with like UTMB, everybody, all these universities that I barely even know the acronyms for currently as a 2-year newbie here. But what's great is we're meeting patient communities. We're bringing them all together so that there's wisdom here and collaborative possibilities leading to more science, more grants, and also better patient care. A fun partnership that's appeared for me is that the chaplains came to me and they said, you know what, we have funds and we want to start studying questions in the areas of faith and how faith is influencing health. And so I'm sitting there cheering them on as they build a partnership, and they want to build, people interested in questions of faith being able to be studied and published through Houston Methodist. I'm excited as usual with digital storytelling and public campaigns. I'd love to have that increase our living donation rates. I'd also love for that to increase people's awareness that transplant is a possibility, that living donation is something that people do. But my biggest goal now is there's only one of me. And I was a young buck, and now I'm a full professor and an endowed chair, and we need more people like me. And they don't have to just be researchers. They can be their own expression of their mission, but we need to build the next generation of diverse leaders interested in patient and community engaged research here. I think that the experience I've had in the 20 years of me doing this can be really helping people grow and launch. And my team just keeps showing up and demanding leadership. I want to just be a welcome invitation for partners, for collaborators, for scientists. I think that this place, with the eye care values that you so steadfastly stand for, we could be a national center for patient and community engaged research, that everyone comes to us for training, for compassionate research, for discovery of innovation. So I want to leave with a quote by Amanda Gorman. Let us not return to what was normal, but reach toward what is next. This is where I've always stood. Sometimes people think I'm foolish. Sometimes they at the end of the day think it's real, but I want to say that this is what I believe, and I'm here to have big dreams and to partner with all of you amazing, good people to see what we can build together. And if you want to learn more about my lab, just take a picture of this and please email me as to your thoughts. I'd love to get to know more people at Houston Methodist. And I want to thank my team for being here, for the people that hired me, and also for the various partners who are here to celebrate what patient engaged research is all about. Thank you so much.
Great. Good afternoon, Dr. Waterman. This is Roger Rosas from HR. And
Hi.
How are you? Thank you. Thank you so much for this incredible presentation to learn about your personal journey with your family, with your career. Really impressive. Thank you. This is a great experience for all of us to learn about, the type of partners that we work with. So it is highly appreciated that you took this hour to learn about you. Thank you. Appreciate it. Tamara also just joined another meeting, so I just want to say thank you in the name of the Human Resources team for giving us this opportunity to learn about you.
Great. I'm honored to be here. Thank you all so much for coming.
Thank you. Take care.
Take care.
Bye-bye.